Okay, so welcome everyone. I hope everyone's been able to join this session successfully. Okay, so thank you for everyone who's joined. I'm very pleased to welcome our guest speaker today, who is Professor Jayant Vaidya. He's a breast cancer expert who specializes in the diagnosis and treatment of diseases of the breast. He's a consultant surgeon and he divides his time between research and clinical work. He has been the pioneer of the target intraoperative radiotherapy, which you'll hear a lot about today. And he's received a lot of international acclaim for this fantastic work that he's done in this area. So without further ado, I will let Professor Vaidya introduce himself and he will deliver a fantastic talk for us today. And then there will be an opportunity at the end for you to have a question and answer session with Professor Vaidya, where specifically, as we've discussed before, you should look to try and identify further any questions around the clinical need, how the particular technology addresses that clinical need, and any questions you might have about the engineering aspects as well. So thank you very much, Prof. I will hand over to you.
Thank you very much. I was asked to talk by your medical sciences, Faculty of Medical Sciences, about this being a breakthrough. Now, it's not us who have said it is breakthrough, and it could be called breakthrough because it is something that could make a difference to women with breast cancer. And in 2018, 2 million women were diagnosed with breast cancer worldwide. 626 women died from breast cancer. And that adds to about 6.3 million women over a course of 10 years. And so a small difference in this subject could make a big difference because it affects a large number of women. It is NIHR, National Institute of Health Research, included, and this was completely unbeknown to us, that they included TARGIT amongst 5 major healthcare breakthroughs. So, and that was in the same list as the COVID vaccine, as well as 2 COVID treatments, which was something we felt was quite nice to be included in that list. The talk will be in these 3 parts. So first is the problem. What is the problem with the standard management? What was the problem with the standard management of breast cancer? What was the new idea? That is targeted intraoperative radiotherapy. And that is how we coined it, TARG-IT, so target. So it's a new concept of delivering radiotherapy to the tissues by doing it in an operation theater. It's a new operation with a new machine. And to test this in an international randomized trial, to test, trace, and disseminate rather than isolate. So trace is to investigate whether it actually benefits, whether those benefits are proven or not, and then worldwide adoption. This has taken 25 years, and I'm going to divide this in four parts. So in the beginning, I would like to acknowledge the teams. This is a multidisciplinary team, a photograph taken in March 2000, where we sat together to discuss every patient care, and this is where new ideas would first start being discussed. The clinical teams in 11 countries, 33 centers, the centers are listed here. So this is the steering committee of the whole trial. These are the names of authors and photographs of the writing committee. And these are the photographs of the authors of the last papers. And this is a list. Each and every person has given all their time. It's literally blood, sweat, and toil. So it was because of the passion for patients. And patients, unfortunately, because of GDPR, we can't write their names here, but thousands of patients and their families have given themselves to be part of this trial. These are my potential conflicts of interest as grant funding from NIHR, Department of Health, and honoraria and travel reimbursement from Carl Zeiss. So let me start at the very beginning. In 1991, I was a senior resident a chief resident in a tertiary referral center in Tata Memorial Hospital in Mumbai. And I would be telling patients a diagnosis of breast cancer, saying, you have breast cancer. And that itself was not a nice thing for women to face. And this woman has to immediately think whether she can actually stay in Bombay for 6 weeks after her operation and come to the hospital every day for 6 weeks? And if the answer to that question was yes, I could say, yes, we can preserve your breast. And if the answer to the question was no, we would have to say, no, we have to remove the breast and do a mastectomy. Now, you must be puzzled why she has to think about waiting in the hospital in the city. And many times they would be sleeping on pavements because there was no accommodation and they came from far away, far other parts of India. And why would they be talking about waiting for 6 weeks after the operation when the operation is done and finished? The reason for this, I have to go back more than 100 years, 150 years. So go back 130 years to William Halsted. So William Halsted was a brilliant surgeon, and he was very meticulous and very good in his operations. And in those days, antiseptic had just come by and everybody had to wash their hands in carbolic acid. And this second picture, it's a side story here, is picture of Caroline Hampton, who was his chief nurse. And her hands were sensitive and she got dermatitis, pretty nasty dermatitis because of the carbolic acid. So he went and spoke to Goodyear Rubber Company and asked them to make gloves. So that is how surgical gloves came into being. And she started using gloves and everybody started using gloves, and it was in fact better for everybody. Quite aside from that, well, he married her afterwards. The operations he conducted were in these type of rooms, which were called operation theaters, and which is why the word operation theater comes into being, which is still used in the UK, but not in the US. And he devised an operation for the cure of the cancer of the breast. And he presented these data in the, after having treated patients. And in this manner, for the first time, these women with fungating ulcerating cancers got relief from this tumor. So a lot of these patients got cured, but 60–70% of them, the cancer came back elsewhere in the body. So people wondered whether it's really important to do such a radical operation. And this radical operation, warning for a picture which can be distressing, you can see it is quite a disfiguring operation. It can lead to problems in shoulder movements, lymphedema, and still women died from disease elsewhere in the body. So this was challenged. So this is the idea of challenging the dogma of radical surgery. And this was challenged in the 1960s to 1950s to 1990s. One of the pioneers in this was Bernie Fisher. He was a surgeon again, and he did what is called as randomized trial. So he devised the idea of randomly allocating patients who were otherwise similar in every other aspects to receive less surgery versus more surgery. So that it's not surgeon's choice that makes a difference. Only difference is the treatment they received. And what he found that this did not make a difference in patient's outcome. So therefore, it became standard that lumpectomy plus radiotherapy was as effective as mastectomy. And that brings us back to our problem. So local treatment of breast cancer in the 1990s was lumpectomy, which needed radiotherapy, which had to be given over a course of 3 to 6 weeks, because if we gave all the radiotherapy in one go, it would get such severe toxicity that the breast might even fall off. So radiotherapy had to be given in small doses. It was given from outside, and that's why it had to be given in small doses so as not to have toxicity. If people couldn't have radiotherapy, then they had to have a mastectomy. Otherwise, their cancer would come back. So that was the question led to this idea, can I stay in Bombay for 6 weeks? So a standard treatment would have been cancer operation, and woman has to go every day for 3 to 6 weeks for radiotherapy to the hospital. So why should women be obliged to choose a mastectomy? This was the problem I was facing in the clinic. And this problem is not alone. India was not the place where it was there. It is there in Australia, it's Denmark, in USA, where people don't want to cross the Bay Bridge on the west coast of America to take the radiotherapy every day. And in the UK. In the UK, if you look at these red dots, each red dot represents a radius of 13 miles. So anybody in the green area, and you can see a lot of UKs in the green area, has to travel for more than 26 miles every day to take the radiotherapy, which in parts of the country would take 4 hours a day. So this was prohibitive to many women, and they choose a mastectomy. So it is not a problem limited to rural parts of the world. It is present in modern world as well. developed world as well. So this concern about patients with breast cancer was serendipitously came together when I did this whole organ analysis of mastectomy specimen in 1994-95, in which after having done the mastectomy, we froze this and then sliced it every 5 millimeters and examined these with X-rays and microscopy. And what we found that when we plotted any additional tumors found in such a breast, which was a small cancers, they had other cancers in the breast. And these were present all over the breast. So breast has many other cancers in the same breast. But this is in contrast with what happens in real life for that patient. If a cancer comes back, 90% of it comes back near the primary tumor, as you can see in these red dots here. So that gave us a paradoxical solution, and we published these in the British Journal of Cancer and in the Lancet, along with Michael Baum and Jeffrey Tobias, that we felt if cancer is coming back in the areas around the tumor only, other areas which we look like cancers under the microscope probably don't grow. So why not give radiotherapy only to the primary tumor area immediately after lumpectomy? So to recapitulate, traveling daily for radiotherapy was onerous. Many choose mastectomy instead. And biologically, local recurrence appeared to be near the primary tumor. So this academic insight gave us the idea to radiate only near the primary tumor. This is what we call as partial breast radiation. And we said, why not do it during the lumpectomy operation itself, so patient doesn't have to come back again for it. So this is how TARGIT was conceived. We created a device with industry collaboration. Surgical technique was invented, and we did pilot studies to show how it is safe to do this in a normal operation theater. And then we did a randomized trial to test whether it is as effective as standard radiotherapy. So that's how it looks in the operation theater. So this is the cancer removed, the tumor bed. This spherical applicator, which we devised, would go into this tumor bed, and we give the radiotherapy in this manner. So there, the three of us did this originally, Professor Michael Baum and Professor Jeffrey Tobias. Professor Jeffrey Tobias is the radiation oncologist, and Professor Michael Baum is a surgeon. So what we were challenging was the dogma of giving radical radiotherapy to every patient. So as I've said, radical surgery was challenged to make it more targeted surgery in the 100 years from 1894. And the last 25 years, the challenge has been to reduce radical radiotherapy to more targeted radiotherapy. And this is, I would say, goes hand in hand with the motto of UCL. When you go on UCL website, disruptive thinking, right? So, but what I'm trying to say is it is patient-centered disruptive thinking. The patient remains the center of our attention. Even if everything else gets disrupted, it doesn't matter. Patients should remain the center of our care. Okay, so now at this stage, I'm going to change the way I project these slides. So bear with us for a second. So yeah, the slides cover the whole of this, so you don't see me in the corner. So how is the normal standard treatment? You have cancer operation. Every week, the patient has to go back and forth for 3 to 4 weeks for her operation. So we believe that women shouldn't have to choose between these two options. So by giving radiotherapy during the operation itself, we would finish the surgery and radiotherapy at the same time in 20 to 30 minutes. That was the idea. So here you can see the X-ray source and the applicator. It goes in the bed, tumor bed, and it's tied with a purse string. So radiotherapy is delivered immediately after lumpectomy. Focused radiation is given to the tumor bed. It targets tissues at the highest risk of relapse and avoids normal structures, example, the heart and the lungs, on the principle of precision and immediacy. And it is individualized. So we can choose the applicator size from 1.5 to 5 centimeters of various diameters, depending on how small the tumor was and how much excision has been performed. For the engineers amongst you, what happens here is electrons are generated and accelerated by high voltage through that box. And I'll show you how it looks. I don't know whether you can see me. That's how it looks. So that's the device. It's quite small, and electrons are generated here. They go along this tube, hit the gold tip, and they're modulated by this spherical applicator, which is inserted into the tumor bed. So these soft X-rays are produced with only 50 kV. So it is ideal for patients during a pandemic. So here it is me using all the COVID gear, putting it in the patient. It's covered and kept in the routine operation theater. You don't need any special lead-lined walls. And that's how it looks during the operation. So we published the technique in 2001, 2002, and the first 25 patients, we showed that it was safe to do so and possible to do it in a routine NHS hospital. Then was the next step of clinically testing whether it's as effective or not. And that is where we do a randomized trial. By randomized trial, I'll explain once more, the allocation is random. It is not because of whims and fancies of the doctor. So every patient who is eligible to have a treatment with breast conserving surgery, that is lumpectomy, are randomly allocated to receive their radiotherapy during the operation or afterwards. So everything else among these patients is is similar to each other. So recruitment occurred between March 2000 to 2012. So this type of randomized controlled trial is a gold standard for testing any new treatment. So that was the random allocation. 2,298 patients were participated in this. They simply had to be over the age of 45 because younger age is a higher risk of relapse. So we thought we should be cautious. And they had to have a single cancer and preferably less than 3.5 centimeters. We started in year 2000 and slowly had other centers participating from all over the world. So we have long-term follow-up. So this is the accrual, and this is the funny part here. So when we started the accrual, people thought we were mad, really. And after about 3 or 4 years, people thought there is something here. So other centers started coming into our fold. And then slowly it went up exponentially. So then they thought, yes, yeah, let's do it. And then why didn't we think about this first? So you might have heard this saying, first they ignore you, then they laugh at you, then they fight you, and then you win. So we are somewhere in the last 2 parts of this. So the first publication came out in 2010 in Lancet, put our conclusions on the front page masthead, in which they said, this is what we said, our conclusion that for selected patients with early breast cancer, single dose of radiotherapy delivered at the time of surgery should be considered as an alternative to whole breast radiotherapy. And it got a lot of publicity all over the world. So everybody started wanting to have this treatment, but we had to still continue randomization. And in 2012, we completed the recruitment, and 2012, we were told by the data monitoring committee we should analyze, and we published the second results in 2013. These are the 5-year results, and our initial conclusion still was valid. And again, it was in the news, and in Australia, soon after that, they recommended IORT for government funding. So while waiting for long-term results, many of the obvious benefits were confirmed in the following studies. Firstly, cosmetic outcome was superior with TARGIT IORT. The San Antonio Breast Cancer Conference we presented this in 2013, and again, it was confirmed in 2003 and then 2013. Quality of life with TARGIT IORT was superior, and this is confirmed in studies in Germany and in Australia, that all the radiation-related side effects were fewer. Patients had less pain, less arm symptoms, less breast symptoms with TARGIT IORT compared with EBRT. And this was a study in Denmark as well. What is the patient preference then? It seems obvious, but we did studies and which confirmed that not only do patients want TARGIT IORT compared to other treatments, but even the doctors would want the same treatment if they had breast cancer. And there's a more recent study about this, which I'll come to in a short while. What about the cost? It is so much less expensive to give radiotherapy during the operation theater, including the machine cost. So on average in the US, IORT would save $6,000 per patient over 10 years. And as US, the cost of giving radiotherapy is so high, the economic burden to US economy, if TARGIT is not implemented for 5 years, is $1.4 billion. So they would save $1.4 billion. In the UK, the cost is again less, but it is in absolute terms is smaller. About £9 million per year would be saved in the UK because it is cheaper to give normal radiotherapy in the UK. And this is an interesting study here. done by Mr. Coombs and Joel Coombs and Uma, in which we tried to estimate how much travel time would be reduced by taking Target IORT. And this is a video which was shot by Mr. Coombs, a surgeon who works in Swindon, as his patients trying to imitate what his patients would do. So you can see this.
I realised that while I'd be driving this only once or twice a month, most of my patients would be asked to drive this at least 3 or 4 weeks for the radiotherapy. What a horrible journey I thought they had to put up with.
That it could reduce global warming, because every patient who has this reduces 30 hours of travel, 215 kilograms of carbon dioxide. Another interesting biological thing which we found is that when we do surgery, and this is scary for surgeons, when we do surgery, the body tries to heal. And when it tries to heal, it produces lots of proteins and cytokines, which are in fact stimulatory to cancer cells. It increases their proliferation, increases their movement, and increasing their invasiveness. The nice thing was that when patients have intraoperative radiotherapy, that fluid that collects in the wound after intraoperative therapy seems to not have these stimulatory effects. And this can be seen objectively with these graphs. And these have been done by video microscopy. You can see the top line, the cells are moving a lot. They're moving less here. And this has been objectively measured and confirmed to be the case. So this was yet another way in which intraoperative radiation, given at the time of surgery, at the right time, at the right place, even though the dose is small, is as effective or probably more effective in other ways than giving it after the operation. So that's end of part 2. So this is the Target A randomized trial comparing radiotherapy during the operation in most patients and whole breast radiotherapy in others. So what we're talking about here are long-term results. Breast cancer has a long natural history, so long-term outcomes are important. So someone has just entered, which is fine. So we're talking about a randomized clinical trial comparing radiotherapy given during the operation after lumpectomy for breast cancer compared with whole breast radiotherapy. And because breast cancer has a long natural history, long-term outcomes are important. The first patient was randomized in year 2000, and the final analysis was in 2020. So we have really long-term follow-up. What is important when we have long-term follow-up is that the follow-up should be complete. Whether the people are alive, have local recurrence or not, the follow-up should be complete until now. So we set the completeness of follow-up bar really high, which meant that we really had to work very hard. And to do this, teams all over the world really worked hard to get the latest data from every patient randomized. And we set the bar so high that we said at least 95% patients should have complete follow-up. The trial management team in the Division of Surgery and Interventional Science at UCL were instrumental in making this happen. So consequently, this trial has one of the largest amount of long-term data. And if you see these skyscraper graphs, these are trials of partial breast radiation. Target was one of the first trials in this. And you can see each of these bars shows a number of patients with that many years of follow-up. And it is one of the biggest in the whole set of trials here. In addition, Target A also had a significant proportion of high-risk patients who are at higher risk of relapse. So they were not just older patients who have a lower risk of relapse. 85% patients were younger than 70 years of age. There were a significant proportion of patients who were higher grade, that is more fast, multiplying more fast, ER or PR negative. Patients who also have a poorer prognosis. They also had 22% patients who were positive lymph nodes. So they were not all low-risk patients. And the risk of these patients of having a relapse was much higher than other trials of partial breast radiation or trials of no radiotherapy. So this is the highest level of evidence that one can have for a new treatment. And what is good is these are 10 countries and 32 centers all over the world. So the results are more easily generalizable to every part of the world. So we have already seen the advantages of radiotherapy given during the operation. The two treatments are completed at the same time. There's less travel, which is an advantage during a pandemic. There's good and better cosmetic outcome. There's less pain. and fewer complications and lower toxicity. But the most important question for a patient is what is the chance of the cancer coming back? And these are the results I'm going to show now, the most important slides. And these data have been published in peer-reviewed journals of high impact, the British Medical Journal, and in the British Journal of Cancer by Nature publications. So the first question, what is the chance of remaining cancer-free in the breast? So what is the local control of this particular treatment compared with others? What you find is that the local recurrence-free survival is no different between the two arms of the trial. So local control is as good. And this is further elucidated in this analysis of subgroups of patients with different types of tumors. And what you find is that the local control is the same between the two groups, irrespective of the tumor size, grade, lymph node status, or ER, PR, or HER2 status. And this is really good news. Now, there is one thing that has been known about breast cancer is that if one has lumpectomy followed by radiotherapy, and if a patient gets a local recurrence after having received whole breast radiotherapy, then her outcome is relatively poor. It's worse than those who don't get local radiotherapy, don't get local recurrence. And this is what we found in this study. So this graph has 4 lines. The top line is the hazard of dying from breast cancer after a local recurrence, after whole breast radiotherapy. And outcome is much worse than if you don't get radiotherapy. So that is if you don't get local recurrence. So this is patients who have received lumpectomy, whole breast radiotherapy, and local recurrence. And this is their chance of dying over a course of 12 years. And one of these lines is patients who received whole breast radiotherapy and did not get a local recurrence. But what are the other 2 lines? And that is the beauty of these results, is that what we found is the long-term hazard of patients who get local recurrence after target IORT is the same as those who don't get a local recurrence. So this is really good news. It shows that the outlook, even after the rare local recurrence, is excellent if they have received intraoperative radiotherapy. So this is consistent with what we found, and in terms of raw numbers, and it's reassuring to patients. Then what is the chance of my preserving my breast? For this, the 2 arms have done equally well. As you can see, each of these lines, sorry, I should have explained this better. These are Kaplan-Meier graphs. X-axis is the year, Y-axis is survival. And this is 100% at the beginning of the study. As years pass, every time a patient has to lose the breast, it goes down. And if the lines are on top of each other, that means the 2 grams have done equally well. So this is what you can see in local control for mastectomy-free survival. What is the chance of remaining cancer-free elsewhere in the body? Again, the 2 lines representing the 2 types of treatments are the same. What is the chance of dying from breast cancer or survival from breast cancer? Here, the graphs are a little more magnified, as BMJ asked us to do. This is 20%, not just 100%, so that you can see if there's any difference between these 2, and there isn't a difference. The 2 lines are overlapping. So survival from breast cancer is no different between the 2 arms. And the next result is the good result, which we found. What about deaths from other causes? We found that chance of dying from breast cancer in other parts, from other diseases like cardiovascular diseases, lung problems, and other cancers was significantly less when patients were randomized to receive intraoperative radiotherapy. And this difference was substantial, almost halving, from 9.85% down to 5.41%. And is this a surprise? It is not a surprise. You may not know this, but it has been very well documented how when you give radiation to the breast, there is some scattered irradiation to nearby vital organs, which can cause harm as years pass, and it is worse as we go further away. So it can irradiate the heart, the coronary arteries, and the cardiac muscle, which increase the risk of heart attacks. So much so that it starts within 6 months. You can see the blood supply to the heart is changed within 6 months of giving whole breast radiotherapy, but not intraoperative radiotherapy because it is focused, targeted, and is limited to the breast. When you give whole breast radiotherapy, the scattered irradiation also goes to the lungs and the esophagus. And this can develop cancers which are much worse than breast cancer. They are many times fatal. So dying from other cancers and heart attacks and lung problems is known to be increased with normal use standard old-fashioned radiotherapy. And this is a study which is a review of several thousand patients in which risk of lung, esophagus, and sarcoma was increased so many times if patient received radiotherapy to the breast using the standard external beam method. Now, this scattered irradiation is avoided by giving targeted intraoperative radiotherapy during the operation where the rays don't pass beyond 1 or 2 centimeters. So they don't get this extra radiation. And in smokers, this risk of heart attacks and lung cancer is magnified because they already have a risk. And so it gets exponentially multiply each other so that a quarter of smokers will die from heart attack or lung cancer 30 years from having had external beam radiotherapy. And this is a 6% increase. And never can the benefit of giving radiotherapy by reducing breast cancer recurrence overtake this 6% increase. So it is really, these data clearly show that the benefit is significantly more. And for smokers, really giving intraoperative radiotherapy is the only safe option. So this is a very interesting part of the data now. This is a very complicated slide, so I'm going to go through it slowly. So when patients were randomly allocated to receive target IORT, we had stipulated that if they were found to have certain factors, they would also receive whole breast radiotherapy. So this is the difference in non-breast cancer mortality, as you can see, getting a wider and wider difference as time goes. And let us now see what happens. So patients who received target, some of them received only target and others in the external beam radiotherapy only received EBRT. So here I'm moving myself slightly higher up here so that you can see this. This is comparing those who received only radiotherapy to the inside the breast with a target compared with those who received whole breast radiotherapy. And we found, yes, there is a reduction in non-breast cancer deaths. But there was a group of patients who received intraoperative who were later thought by clinicians that they should also receive whole breast because they were thought to be higher risk. But what about those patients who received target plus EBRT because they were thought to be higher risk breast cancer compared with EBRT? Now remember, these two groups are similar to each other in terms of risk for other cause of death is concerned. So they don't have a higher risk of having heart attacks or lung cancer or other problems. They only had a higher risk of dying from breast cancer. That's why they received whole breast radiotherapy. So if there is a difference in non-breast cancer deaths here, it wasn't because of avoiding of external beam radiotherapy, but because of giving of targeted intraoperative radiotherapy during the operation at a time when the trauma of surgery is having a systemic effect on the body. We are modulating the systemic effect of surgical trauma by giving radiation to only the tumor bed. And we found, yes, non-breast cancer deaths are significantly reduced if you give radiotherapy during the tumor bed, even after you give external beam radiotherapy. And this is an effect which has been studied over the last decade, and it's called an abscopal effect. Abscopal means away from the site of the tumor. It seems to make a difference in the cytokines, which I showed you in the last few slides ago, that it seems to have an effect on cytokines, which may have an effect systemically on reducing deaths from heart attacks and other cancers. So this is an interesting biological byproduct of this study. Right. So if radiotherapy is causing problems, is no radiotherapy a good idea in a highly selected, super selected good prognosis patients? So I'm coming back down here now. So this was a study called PRIME2 in which older patients with very good prognosis cancers were randomly allocated to receive no radiotherapy. And after 10 years, what did they find? Actually, radiotherapy is required because otherwise 10% of these patients get local relapse. And if 10% patients get local relapse, you don't want 1 in 10 of your patients to get a recurrence and need a mastectomy. And there was no survival benefit of avoiding radiotherapy, perhaps because these local relapse led to distant relapse and death. So this survival benefit was not seen in this study. So it's not a good idea. Next, do patients want no radiotherapy? So this is a study that has come out just this year in which patients over 65 were asked, because of COVID, this was an option given to patients in the UK. They were asked actually, do you want intraoperative radiation, no radiotherapy, a mastectomy, or have whole breast radiotherapy. And 75% of the patients, when given a choice, chose to have intraoperative radiotherapy, and that's what they had. This is in Northern California, Kaiser Permanente, which is as close one can get in the US to NHS. Very few patients chose no radiotherapy. And that is, therefore, it is not something which should be offered to patients as default treatment, although it is being done in some parts of UK, in many parts of UK. This is the other option. This was a trial which was whose results were prejudged and started coming into clinical practice even before the paper was published. But this is the way in which you can give radiotherapy over 5 days alone. And each dose is much higher, but it is given from outside, and it gives radiation to the whole breast. So there is still scattered radiation to the breast. Its effectiveness is similar, but the toxicity is higher. A quarter of patients report hardened breast, and this breast induration is 19 times more as per the physician assessment, and we don't have long-term data. So is this compressed schedule of 5-day treatment a good idea? The data suggests that it is not a good idea. There are other methods of giving partial breast radiation, and I think this is a choice that patients should have to choose between these methods. One of them is using wires. And when patients are given a choice, they should be given all the information about it, including a photograph such as this, is whether this is a way they want to have it. It requires an additional procedure. It requires lead-lined walls, and it is given over 5 days and 10 doses. And scattered irradiation to other organs is still there, and there is no mortality reduction. Another method is to use the same machines which already exist, but it requires an additional planning visit. 10 doses are given over 5 to 8 days, or 15 doses over 3 weeks. There is still scattered irradiation to the organs, and there is no reduction in deaths. So all in all, although I'm biased, the results of Target A trial suggest that this is a no-brainer for patients, and that's what patients prefer as well. So cancer control is as good, and there are fewer deaths from other causes. Now, there is one more last result. If the patients have grade 1 or 2 cancers, these are the less aggressive tumors, and this is the majority of patients really. Nearly 1,800 patients had this type of tumor, and in these patients, there was a significant overall survival benefit of about 4 to 5% in this with giving Target IORT. And you may think, what is 4 or 5% improvement in survival? Is that something worthwhile? To put it in context, I'm giving you an example of Herceptin. You might have heard of Herceptin. About 10 years ago, there was supposed to be postcode lottery. This is a new drug, which is a targeted biological therapy. It's a wonder of research, effect of research. And this drug is expensive. It costs about $50,000 in the US, and it is given over a course of 1 year, once in every 3 weeks. It damages the heart. And the benefit in patients who have got up to 2 centimeter tumors and ER positive cases is about 4.5%. So it's about 3 to 4%. So this benefit with Target, where it actually protects the heart and is less expensive, is similar to this highly expensive drug. So our results, which were published in 2010, have been now amplified. We can now say that this is widely applicable when a lumpectomy is performed. The cancer control, breast cancer control, is similar to standard whole breast radiotherapy. There are substantially fewer non-breast cancer deaths and substantially improved overall survival in patients with grade 1 and 2 cancers. There's excellent prognosis even after the rare local relapse. There is less pain, cosmetically superior outcomes, and better quality of life. It is more convenient for the patient. There's less travel time and lower cost to the patient in the healthcare system. And this may well be the crux. I'll come to it in a second. So this again made news. It was in the front page of the Times, on the top of the front page. So are there any downsides, people will ask? The downside is that it challenges the current dogma. This leads to inertia, and it goes in hand with disruptive thinking. So this is written not by me, but by chief editor of the top radiotherapy journal, saying that depending on your perspective, intraoperative radiation therapy is either a very serious threat or a quantum leap forward. Despite this, it has been shown to be an innovative, good treatment to the patient. It is better than other PBI approaches, and it is enough data to change practice. So around the world, people have started using it because they believe in what is best for the patients. This is a study from China, 281 patients, US, 200 patients, Russia, they have now treated more than 1,200 patients. In France, these are 676 patients. Europe, this is a study only among the age of above the age of 70, where Germany, France, Denmark, and Switzerland have presented their 5-year results, which are very similar to those of the Target A trial. And people using Target as standard of care have been meeting since 2013 in these user meetings. And they have been in Germany, in US, in Far East, in Bangkok. And the most recent one was just before the pandemic in February 2020. And I was a bit scared when I went for this meeting in New Orleans. And I have contacted centers from all over the world. There are 260 centers currently using it as standard of care in 38 countries. And each of them have given me the number of patients they have treated. And after totaling it up, it comes to at least 45,000 patients as of October 2019, early 2020. So over the last year, that number will have gone up. So this is the number that is done. In the UK NICE committee recommended this as standard of care in 2014. And it got a lot of publicity. NICE tweeted it. And NIHR has included it as one of the 5 major breakthroughs. When Target IORT is to be offered, it is done by doctors. It then follows, they follow GMC guidance, NICE guidance, and the law. Because now by law, doctors are meant to give patients all reasonable options, which have been shown to work, irrespective of their own thoughts about it. I want to end by a short video of patient. So you can scan this to let me know your thoughts. By the time I get the video on.
I'm Marcel Bernstein. 8 years ago, I was diagnosed with early stage breast cancer. I had it for 2 months only before I was cured. I had Target IORT at the same time as the operation to remove the cancer. I spent 1 night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had Target. I am so happy I was able to have this treatment.
Okay, thank you. Thank you very much. Yeah, I'm happy to take questions.
Thank you very much, Professor Vaidya. That was absolutely fantastic. And I think that was a very fitting way to end the presentation with the patient giving her sort of story as to the impact that it's had. I think that just conveys quite how significant this development has been. So we'll open the session to questions now. So I would invite all of the students to come forward with any questions they might have.
I don't really have any questions, but I just wanted to say that because I thought it was really clearly explained, but I just wanted to say that I found it really interesting and just to congratulate Professor, because obviously it's an amazing treatment and it's a really good solution.
Thank you. Thank you. We are, in terms of the future, we are continuing research in this regard in what is called as Target B trial. This was Target A trial. B trial are those patients who would not have been eligible for Target A because they're too young, younger than 45, or thought to be very high risk with multiple positive nodes, or if they have received chemotherapy before the operation. And Target B is again funded by NIHR, HTA, and they are randomly allocating patients to receive some of the radiation during the operation, and they receive whole breast radiation in addition. Both arms, both groups receive radiation to the whole breast, but the boost to the tumor bed is given during the operation or afterwards. And we want to see if it makes it superior in terms of cancer control, and also whether giving Target actually reduces non-breast cancer deaths. So that trial is now recruited nearly 1,500 patients, and we want to get up to 1,796. And there are 38 centers in about 15 countries recruiting.